Greetings of the season. I am Dr. Vijay Warad. I am a practicing allergist, clinical immunologist at Pune since last 27 years of my practical experience. See, last so many years we have seen upsurge into the allergy patients. So it's a number one chronic disease in children. In adults in Pune like city, every second person is having some or the other allergy. Overall in India, every 1/3 of the population is suffering with the allergies. And in that, the food allergy cases have increased a lot nowadays. Around 7 to 8 times admissions into the children happen because of the food allergies. The severe food allergy can be there. Even the anaphylaxis cases also with the food allergies has increased in India. Not only the children, it's most common in the children. Around 5 to 8% of the children may have a food allergy, whatever the documented data in India is there. Adults also, around 1 to 2% of the adults have a food allergies. So the children means up to adolescence, 18 to 20 years. And above that, the adults are there. So basically the genetics has changed. So it changes always because of the use of pesticides into the foods, the farming, the artificial fertilizations, then the adulterations, additives, coloring agents into the foods. The lifestyle has changed, overused air conditioners, the refrigerated products, the sleep pattern change, stress factors, indoor and outdoor pollutants. Adding on these effects, considering the genetic tendency of the patients for the hypersensitivity, as well as these food proteins causing a more severe food allergies, and which leads to the severity of the symptoms and the disease. As compared to the food allergy in the Western countries like in USA and all, they have a lot of peanut anaphylaxis and all. So that's why every third child, they keep the EpiPen ready to use adrenaline injection in their school bags and all. But in Indian scenario, our food allergies are slightly different. Like we have a more lentil allergies. We see a lot of lentil allergies. Milk allergy is the most common amongst the children, followed by the egg, then soyas, then some of the patients having fruit allergies also. The nut allergy is very common besides the fruits, like almonds, cashews, pistas. Then the lentils, the Bengal gram, the masoor dal, arhar, urad dal, these also cause a lot of problems. Then we have seen practically also, like the Bengal gram in the farsan, whatever with the mix chats and all, that added spices and all, it triggers a lot. Again, practically, we have to differentiate between the food allergy and the food intolerance. So most of the patients, the primary food allergy is less. Other patients, it can be the food intolerance. Food allergy means within 2 to 3 hours, the patient should have a significant symptoms. And what are the symptoms in food allergy? Severe cramp like pain in abdomen, puking, throwing from above or down like a gastritis or enteritis. Pain is very severe. Cramp, it does not resolve with the simple painkillers or antispasmodics. Then the child or the adolescents start having a urticarias, swelling of the eyes or lips or other body parts also, angioedema, sweating, hypotension, giddiness, blackouts or something. He can collapse like a shock. So these can be the severe food allergy symptoms. So we have to differentiate accordingly. Some of the patients may not have a severe anaphylaxis, but moderate to severe symptoms, like even they may start with the sneezing or throat irritation, itching or itching in the hairs, scalp or hand, foot, urticaria, some swellings here or there, eye or lips or something, or some choking of throat. So this can be moderate symptoms along with the gastrointestinal symptoms also can be there. And mild symptoms maybe just a cramp, some indigestion or something difficulty, discomfort into the abdomen and all also can be there. So these type of different symptoms in this food allergy. So but the most characteristic is that each and every time, even the smaller amount of the food should introduce the reaction, then only it is a food allergy. So suppose a child having a 1 or 2 drops of milk also, each and every time the symptom should be reproducible, then only it is a food allergy. Sometimes after having a milk the patient has a trigger and sometimes it is not there, then it is not a food allergy. It can be the coincidence with primary allergens increasing the mast cell, the gut inflammation, at the same time if the child is having that milk and there is a cross reactivity like oral food allergy syndrome, the epitopes of the food and some of the pollens, they have a cross reactivity. Like for example, suppose somebody has a latex sensitivity, these children have a cross reactivity to the citrus fruits like banana or avocado and all, so they get a trigger because of that. So birch pollen has a cross reactivity with apple, the Maldivian antigen. Prawns, after having that, patient has the tropomyosin has a cross reactivity with dust mite, derp1. So that way we have to identify, is it a oral allergy syndrome? Because oral allergy syndrome, after having that, most of the symptoms are limited to the leaves or below the tongue or in the oral cavity, but the systemic symptoms are not there. Food intolerance is a big chunk. Most of the patients have a food intolerance. After having 1 or 2 eggs, after 4 to 6 hours, evening or next day morning, they have a symptoms of urticaria or stomach upsets and all, or angioedema or something. Then it is a food intolerance. So that is more easy to manage. We can develop a slowly tolerance to those foods. But if it is a primary food allergy, each and every time in a smaller amount of that food is having a severe reactions, as I mentioned about that, then we have to stop that food completely. Because the management into that is the only avoidance. As I mentioned about these signs and symptoms about the food allergies, like IG mediated food allergies, we talked about that. Now there are some children with a non-IG mediated food allergies, like proctocolitis, then enteropathy is there, or yappis, like severe reaction leading to the bloody diarrhea or severe vomiting causing a dehydration. So these yappis are seen mostly in the infancy, where most of the patients have a milk, soy allergy and they have a significant the reactions. So like a toxic reactions are there leading to the dehydration, bloody diarrhea and all. So that is also very serious, but there it is a clinical diagnosis. We just do the test for to ruling out the primary food allergies, and then slowly we have to have a trials of these patients as the child grows. Then slowly we try to introduce and develop a tolerance, or then the patients can tolerate those foods. So that is called a non-IG mediated. Then proctocolitis, basically these are bloody diarrhea, then the lower colon and colon they are involved into that, and these patients have a loss of appetite or failure to thrive and all. Then enteropathy patients, significant enteropathy is there because of these foods and the specific foods, and they cause a bloating, stomach upsets, not having like loss of appetite and not gaining weight and all. So those are the non-IG mediated allergies. So that cases are rare, but we have to keep in the mind because we can identify that. There can be overlap of these non-IG and IG mediated food allergies also. So we have to be very careful because later on these patients can go into the actual food allergies also. Then again the food intolerance also, some patients may develop a significant food allergy. So keep these patients watch, explain to the parents that this is may not be a now primary food allergy, but later on some of the patients can develop a food allergy. Food allergy and drug allergy can be developed any point of time in any part of life. So it can be a varied presentations. While managing these patients, avoidance is the important one. There are blood allergy tests, there are standardized skin prick allergy tests. In blood allergy tests, the ELISA and RAS testing is outdated. Component resolved diagnosis, multiplex or single assay method also is available nowadays in India. If we suspect a milk or egg or soy, then always do the single assay, these 2-3 foods only. We can differentiate the specific epitopes in these patients, so we can guide the patients about the what precautions and all. Some of the patients have a food induced exercise triggered severe anaphylaxis or urticaria angioedema. There this component resolved diagnosis can help a lot. Suppose some patient after having a heat in that day, if they do a heavy exercise, they have a exercise triggered food induced anaphylaxis or something. There, those epitopes which are identified, like gliadin into the feet, that helps the patient to avoid it, and later on he can develop tolerance to that exercise also. So that way it helps. So those tests can be done. Suppose some patient, there are multiple foods, the parents say, very few patients are there where they can't tolerate any foods, multiple food allergies are there, significant clinically also. Then we can go for this multiplex assay component resolved diagnosis, where we can identify the sensitivity level. After the allergy test also, we have to always clinically correlate then only, because the sensitivity into the blood allergy test may not clinically correlate always with the food allergy or symptoms of the patients. So we have to clinically correlate properly. Standardized skin allergy tests have a role as a negative value. Suppose some patient are showing a sensitivity into the component resolved diagnosis or immunocap specifically. CRD though, we have epitopes, but in the immunocap blood allergy test, sensitivity may be there, but suppose the skin test is negative, so that negativity of that compared with the histamine positive control is more important than the positive. So in food allergy patients, skin prick test has a more negative value, like negative value of that food is more important. The positivity can be because of the crude extracts also. The component resolved diagnosis is the ideal one in a food allergy patients. Immunocap blood allergy also test can also be done in some patients, but nowadays actually the CRD is more helpful in food allergy patients. If it is a food intolerance, then slowly the food is introduced in a very slow amount, SOTI therapy it is called, and slowly that concentration can be increased after 4 to 6 hours, like suppose milk, 1 drop, then 2 drops after 4 to 6 hours, after 8 hours, 3 drops. Slowly come to that level where the patient can consume as a normally, then daily that food should be given and the patient can tolerate to that. But before that, we have to control the gut inflammation properly with some probiotics and some mast cell control, montelukast or bilastine or fexofenadine medications and all. That also can help. Or suppose there is a multiple food allergies or severe food allergy. Now omalizumab has shown a very good results, which is a monoclonal antibodies against the specific IgE and which prevents this IgE binding to the mast cells. I am using last 6 to 7 years the omalizumab into the food allergy, and recently even the FDA has approved this omalizumab. So even nowadays some biologics like dupilumab and other biologics, penralizumab and all, the clinical trials are happening in anaphylaxis patients and all. In the future it can be useful, but now at present the omalizumab has been very well approved. So these biologics also can be given. Even these patients with food allergies sometimes may have a eosinophilic esophagitis as an overlap syndrome. So we have to identify that. Accordingly, we have to treat those cases also. So there is an overlap of this primary IgE mediated as well as non-IgE mediated, or the celiac disease, or as just now I mentioned about the eosinophilic esophagitis and all. So we have to consider, very few patients are there, but we have to consider those also and we have to treat accordingly. The gold standard diagnosis for the food allergies is the oral food challenge test. It's a double-blind, placebo-controlled oral food challenge test. But practically in India, nobody does it because there is always a chance of severe anaphylaxis. But definitely future, once the patients have awareness and the acceptance will increase, we can also practice about that. But that is the gold standard. And long-term wise, to improve the quality of life and to avoid the mortality in the food allergies, always suppose some patient has a prior history of anaphylaxis, guide them to keep a ready to use adrenaline, like our own Indian jugaad we can say, the 0.5 ml adrenaline, 2 syringes in a 2 cc with a regular 24 needle in a spectacle case also can be kept in a 30 kg above the people. The children, simple to remember, like 10 kg child 0.1 ml, 20 kg 0.2 ml, 30 kg 0.3 ml, above that 0.5 ml. These 2 syringes should be kept always them. Awareness amongst the community is very important while managing the food allergies. Lot of awareness into the schools, colleges, into the restaurants and the resorts, because still it is taken very casually. There are no strict guidelines or no like there should be the leaflets where they should mention, like suppose somebody has a food allergy, inform any outlets of McDonald's or something. Outside if you go there, every restaurants and all, even the menu card, they always mention about that. But in India there is awareness is lacking. Even the food packets and the food processing industries. So at every level the awareness about the food allergy should be there to prevent such a severe reactions and the complications of that, and to not to lose these patients, because a lot of anaphylaxis deaths happen even in India also, and they are not diagnosed properly. So we can prevent these complications. And as I mentioned, the genetics and the lifestyle has changed and the adulterations and all. The cases have increased. Only thing we have to identify in an early stage.